Good morning, everyone. It's time to start our medical retina session, cases that intrigued me. I'm glad to moderate this session. I'm Dr. Magdi Musa from Egypt. Let's call the first speaker who will present a case presentation, Dr. Ripush Agrawal. Most of the presentation does not have title, so it will be like a mysterious until we see the case.
Thank you.
Thank you.
Thank you. So there is no title. I'm still looking for a title for my case. Maybe at the end, we can get a title from the audience. So I think this is something for us as medical retina people or as uveitis people. At least that one we know this is involving the back of the eye. Now let's see what this case is about. The case is about a 29-year-old female Chinese secondary school teacher who presented with some visual symptoms, but she had a background history of connective tissue disorders and arthritis and Raynaud's phenomenon. She had this history of weight loss, history of worsening of puffy fingers, history of alopecia, history of night sweats, and painless loss in the vision in the right eye. When we saw this patient, and it was referred to us with right eye central scotoma, and we thought whether this is a retinal vasculitis or retinal artery occlusion secondary to antiphospholipid syndrome with a background history of connective tissue disorder. Now let's look into the picture of what this patient had. So just to summarize, this patient just few days before, which was like Tuesday morning, she started with grayish patch in the right eye with no preceding history of fever, trauma, or COVID vaccine or COVID infection, works as a secondary school teacher, but some systemic disease like with the joint pain, rashes, and hair loss. Already has. Now, when you look into this picture, you will see there are a lot of cotton wool spot, retinal hemorrhages, bilaterally more or less symmetrical, but in addition, there is a funny looking patch here in the central retina on the macula. And also the circle which I have drawn, there is a loss of retinal vessel or attenuation of the vessels here. Now, this is the typical electronic medical record screenshot from our hospital record. As you can see in the right eye, patch of ischemic retina supranasal to the fovea, another very small patch of ischemic retina temporal to the fovea, which was seen on the thing, and multiple cotton wool spots, dot plot hemorrhages, inferior sclerosed vessel, as was written by my registrar or a resident. The Amsler chart, which I do believe everyone still practice, and this does not become obsolete. I do practice quite a lot of Amsler chart, was showing a patch of a scotoma there. And we have designed recently some quantification of the Amsler chart also. This was a visual field also done, which was showing some interesting finding. Fundus autofluorescence, again, showing some bit of a finding here. But this is a finding to be seen on the OCT scan. As you can see, a thickening there, which is suggestive of a PAM-like lesion on the right eye, and again in the left eye, not much findings. Patient underwent a standard test. So all these patients, they go through imaging test followed by certain lab test. The patient had a fundus fluorescent angiogram, which we can see clearly there is a peripheral ischemia in the temporal, but along with that, in the left eye, which was not looking so bad, you can see the severe retinal vascular inflammation. So there is a retinal vasculitis in both the eyes with peripheral capillary dropout in the right eye. Again, on the ICG, you can see there are certain areas which are hyposenescent, which remains hyposenescent even in the late films. So early hyposenescence followed by the late hyposenescence. So just to again put things together, there is a patient, RAI stands for Rheumatology Clinic, who had this symptoms suggestive of connective tissue disorder, but along with that, presented with the worsening or the eye symptoms with certain lab findings, which is showing rheumatology or immunology markers to be abnormal. Now, you must be thinking why I'm talking in medical retina when you don't look into all these investigations. Probably for medical retina is OCT and OCTA and maybe HbA1c probably. But sometimes, even in medical retina clinic, you will be coming across where you might have to open up patient systemic test and see into what's happening. Now here, you can see the other systemic investigations being done, all were unremarkable. Besides, the patient had a history of SLE or MCTD and history of transaminitis. Now, the patient was admitted. What we decided is, looks like there is a significant vascular inflammation. Patient underwent urgent IV methylprednisolone therapy, 3 doses, along with collection which was given, and steroids were given as well. Patient also received immunosuppressive agent. Our rheumatology colleague were very aggressive. They said, no, young patient we should give. And you can see the post-op response, how the patient, over a period of few days, the patch, patient very alert. Every time she comes with a very specific picture. And here you can see over a period of time how the patient is responding. So this is versus over the period of 1 week. Usually I don't repeat it so fast, but in this patient we just wanted to see what's happening. So there was an increased leakage and peripheral capillary dropout. Eventually the patient underwent laser because there was a significant areas of capillary dropout, and along with the systemic immunosuppression, because we don't want the patient to enter into neovascular phase or neovascular glaucoma and neovascularization to be developed. So we had a case of right more than left severe vaso-occlusive lupus retinopathy with increased capillary fallout. Bilateral top-up laser was done, along with immunosuppression was given. Patient is doing well, been under current follow-up for 2 years. In between, she gets a little bit of symptom, but the symptoms got better. Amsler has come back to normal. So I rest my case and open for discussion. Thank you.
Any questions from the panel for the case? Can I ask the audience if you are hearing well? Because we are not hearing well here from the speaker. Can you hear well? Can you hear well?
Here cannot hear. Here because it is echo.
Yes, there is echo on the...
Echo here. There you can't.
There is no
you hear properly.
This is not good.
Maybe you should
Can you help us with that? Can you understand what we are saying here? Excuse me. We have an echo here. We cannot hear the speaker well. So one of these speakers has to be oriented somewhere else, because we don't hear well here, they hear well down there. It happened yesterday. I was hearing well down there. We don't hear, the moderators does not hear well. Something wrong. Can you shut down one of the speakers here? I mean, one of this. Can you shut down one of this or tilt it? Because we don't hear well. Thank you for the case. It was a nice case. Let me ask you about the systemic lupus inflammatory choroiditis. I mean, sometimes it happens not only retinitis and uveitis, it can affect the choroid, and sometimes there is massive vitritis with these cases. Have you ever met a case like this?
Yeah. The question here is whether the lupus affecting the choroid. So I will say maybe we include a couple of other things in that: psoriasis, lupus,
yes,
HLA-B27. We have seen these cases even presenting with posterior segment involvement, not only the retinal blood vessel, but also the choroid. Now, I will say choroid has been underdiagnosed, underreported
yes,
entity. Like what we know that in hypertension, the choroid can get affected. Likewise, I totally agree with you. There is a choroidopathy which is not been reported with SLE, or whether it is with psoriasis, whether it is with HLA-B27 kind of disease. We are seeing quite a lot of things, and it is reported. But it's just that we are not imaging the choroid in the way we should be. We don't do ICG. My typical practice in uveitis or in medical retina is to do both FFA and ICG together to pick up some of those things. And as you can see very clearly here, you could see those choroidal lesions there. I agree with you.
My second question and last one is what's the long-term treatment? Because sometimes when they are quiescent, you taper the steroids, you keep them on what?
Again, very good question. Immediate we give steroids,
yes,
and while we are weaning of the steroid, you start immunosuppressive agent. And that time you can be a bit stronger with your immunosuppression when you start early. But over a period of 3 to 4 months, you can stop steroids. You can keep it at 10 milligram for 1 month, 7.5 milligram for 1 month, 5 milligram for 1 month. After that, you can stop maybe at low dose of 2.5 milligram. While you stopped it, you move them on azathioprine, which is my preferred agent, or mycophenolate mofetil, alkylating agent. But after that, you can keep them for 6 months, 1 year, maybe up to 2 years, depending on how they are responding.
Okay.
This patient was on 2 immunosuppressives because it was long term, but after 1 year, we managed to switch off 1 immunosuppressive. Now he's only on 1 immunosuppressive. And while the patient was on immunosuppressive, you have to make sure that you check the blood count, liver function, and kidney, because you don't want the patient to end up into systemic complications because of the long-term immunosuppression.
Thank you.
Just quickly, sorry because I cannot hear from here. Have you considered intraocular steroid implants? What I mean, something like Ozrex or Oluvin even over the long term, will it be enough to control the disease?
Good. So I think this is again a very important question about the intraocular steroid implant. So my absolute answer here for this particular case is no, because this is a systemic disease. We do know that there is a systemic involvement. The local therapy, if there was a real vision threatening and sitting in the macula, might be considered. But I believe IV methylprednisolone can take care, and local probably will be more harmful in terms of side effect. I have not given that many local, mainly when the patient is having systemic disease with bilateral involvement. My preferred will be the systemic therapy. I have not given and I will not give in these cases. And I've managed many of these cases. This is just one of the prototype cases. Every week we admit such a case, quite a number of these cases we manage with systemic thing. Local is not preferred.
Thank you so much for this informative case. Thank you so much.
Thank you.
May I call the second presenter, please, Dr. Vivek Dev, for case presentation. Can you switch the screens? Because he's on his computer. No, they didn't switch the screen. Switch the screen, please. From here. You have to switch the screen from there. ضايع 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 ضايع. The switch from there. That's what I said. Switch the screen.
Well, I've provided the file, but doesn't seem to be working from there.
Don't worry, don't worry. There's a lag between us and them. It will happen now. No, it will happen. It will happen. Just a second. Take a deep breath and pray. ضايعين ضايعين ضايعين. That's it.
Yeah, sorry for that. Good morning, everyone. I'll be presenting a case which is a medical condition with a surgical implication, and this was something that intrigued me when I initially...
Can I interrupt you for a second? Can you use this? Because we don't hear anything from this one.
okay, sure. Is this better? So this was a 45-year-old female with spontaneous onset loss of vision in her right eye, presenting vision being counting fingers at 2 meters, a well-controlled diabetic, and an additional recent history of dry cough, and few of those coughing episodes were a little explosive in nature. I'll show how it apparently possibly correlates with the presentation. This is what she presented with, counting fingers 2 meters. On the posterior pole, a well-demarcated hemorrhage, which looks pre-retinal, as the blood vessels there are not visible. A small area temporal to its edge, where the bleeding was not as dense as it was in the rest of the central macular area. This is what the other eye looked like. On cursory examination, it seemed as if these are a few hard exudates. There was also some amount of cataract, and she was a diabetic. So putting those things together, possibly some amount of hard exudates, but there was some pigmentation, or at least some darkish reflex, which was little nasal to those seemingly hard exudates that were present in the retina. The OCT through the eye, which had loss of vision, showed a compact hyperreflectivity above the retina. And in such small compact hemorrhages, often we find that this aggregates below the internal limiting membrane. The underlying retina was not clearly visible, but whatever was visible, the layers seemed to be maintaining their anatomy. Unfortunately, the other eye OCT we had missed at this visit. An angiogram was there, which again showed blocked fluorescence, and at the edge where the blood was not as dense, we could see some amount of hyperfluorescence, but did not see a very clear increase in size and intensity. The other eye, though, clinched the possible underlying diagnosis, because there was this fuzz which was temporal to the fovea. Like I said in the fundus photograph, there was pigmentation, so this fitted into PFT, or macular telangiectasia, parafoveal telangiectasia. So we diagnosed the case as macular telangiectasia in the left eye, sub-ILM hemorrhage with right eye, possibly due to a Valsalva retinopathy, going by the history that was present, or maybe due to the underlying macular telangiectasia. Now, at this point, I had never seen a subhyaloid or a pre-ILM hemorrhage come up in such a large vision involving a quantity in a PFT. But we planned for a pars plana vitrectomy with ILM peeling, and the process was as our routine surgery would progress. After a core vitrectomy, you stain the posterior hyaloid, ideally with triamcinolone to get a good grip of the posterior hyaloid, and separate it off. As you see here, a good Weiss ring is getting raised, ensuring that the posterior hyaloid is completely cleared. And once that is done, you stain the ILM with BBG dye and stain the ILM with BBG dye and go ahead and complete your ILM peeling. Now, what happened is once the ILM peeling was done, I could see this source of bleed, which was at the edge of the parafoveal telangiectasia. Raising the bottle height and staying there with my flute for some time, the source stopped and all the bleeding did not continue any further. This is what the post-op looked like with a vision of 612 N12 near best corrected. As you can see in the magnified photograph, this clearly was a parafoveal telangiectasia in the right eye also. OCT angiograms done in the post-op showed the vascular tuft of parafoveal telangiectasia in both the eyes, lesser so in the left eye, but we could see the outer retinal loss, which is consistent with the diagnosis of a PFT. At this point, I did come across this one piece of literature on an entity which was similar to what I demonstrated right now. But even here, the cases had a doubt or a history suggestive of Valsalva retinopathy in one eye, and the fact that two of the other cases in this case series were on antiplatelet drugs. So my intrigue or my question for everyone is, was this just macular telangiectasia which bled, or was there a superimposed Valsalva retinopathy? If it is telangiectasia, the way it was oozing on table, would you cauterize or laser that bleeder lightly? And has the panel or audience experienced such a case before? Thank you.
Thank you so much for this interesting case. I've seen a lot of telangiectasia with CNV, but I've never seen sub-ILM hemorrhage. So this is, very rare, I think, to find out. But my question is, would you give it time to absorb? I mean, why didn't you think of give it some time to be absorbed?
So the patient was very anxious, plus the patient actually had her son who was staying abroad, and she was scheduled to actually fly out to him. So the time frame that the patient had in India was very short at that time frame. So
and I like the message you gave, because always look at the other eye, because you will never be expecting that she is having telangiectasia in one eye unless you looked at the other eye, because sometimes sub-ILM hemorrhage can happen to many reasons, even Valsalva without without telangiectasia. So the clue sometimes in the other eye, but it's very rare to find sub-ILM hemorrhage or intraretinal hemorrhage except they have CNV. Thank you so much for this. Any question from the panel?
I would ask you, why didn't you try to inject? Because it could be a proliferative macular telangiectasia type 2. So, as the telangiectasia can develop macular neovascularization at different levels, not originated from the choroid. So I think if you injected it, it would resolve, and we don't need to do vitrectomy.
Okay, so is your comment that we could have possibly given an anti-VEGF injection
Instead of surgery?
Instead of surgery? All right. Just to go back to that OCT, under the sub-ILM hemorrhage, the retinal structure did not seem to show any disorganization. So CNVM wasn't on my mind at that point in time.
We cannot comment on the disorganization because we have a shadow artifact, so we cannot know truly. But once we looked at the diving veno in the outer eye, it is very suggestive at the change of the foveal reflex. It's very suggestive for macular telangiectasia type 2. And it could be proliferative, and it could be at different levels. So injecting would be much safer than going basically with surgery.
Sure.
Actually, if just I add a comment, I don't think the injections will have a big role here because simply we are talking about Valsalva or even macrotelangiectasia, and most of the literature didn't show any benefits for the injections in macrotelangiectasia. It is a neural generative process more than to be a vascular problem. Anyway, just for Valsalva, if we consider Valsalva because it can present this way, by the way, what will you do instead of waiting or surgery in between? There is diag posterior hyaloidotomy for the focus and disperse the whole thing in the vitreous, and this can disappear by its own. This is just one of the things which came to mind.
Right. That just was not considered because it was so small, right there at the macula. That was the reason. We have usually been attempting it for those which largely cover most of the macula for safety reasons.
Just I agree with Dr. Magdi. Usually, telangiectasia by its own, it will never cause this except if it's superimposed by something like what you said, Valsalva or something. Right. And in this case, time will give the result.
Thank you, anyhow, for this. This is great presentation, very new for us, and thank you for sharing this with us.
Thank you so much. My pleasure. Thank you.
May I call the next presenter, Dr. Muhammad Tawfiq from Iraq. Yeah, the case presentation. I don't like this. Can you turn this down? Turn this down? Yes. Try the. Turn it down. Try the microphone.
I will this one. Yes. Good morning. Can you hear me well now? It's better but before the old microphone have echo, we cannot understand anything on the panelist here. Okay, so again, I hope that you enjoy your stay in Dubai yesterday. It was a very nice day, and thank you very much for the organizer to have me here today. When I was called for presenting here in these sessions, I don't have a strange case. However, I want to illustrate something is we face it in our daily practice about the term of chronic persistent diabetic macular edema. I have no financial disclosure. Let's beginning our journey here by this case. It's 62 years old, male. He's diabetic for a long time. The uncontrolled HbA1c. This is the appearance of both eyes, the right and the left eye, show MPDR with diffuse diabetic macular edema. The VA was 624 and 618. The OCT of the right eye show we have the intraretinal subretinal fluids and huge cystoid macular edema on both eyes on different levels. So, as a general rule, we start usually injecting the patients with a monthly injections of Avastin. In my country, we go for Avastin, first of all, despite we have to respect the protocols, but in order to provide this material, it's present all the time, so we give the injections of Avastin. And for me, I usually give 5 injections before considering to switching or anything. So if we can see here, if we can see here, this is the baseline on right and left eye. We see the edema is not improving. So despite giving the 5 injections and the edema is not improving. So when I go back to the literature, I understand we have 2 terms to illustrate: persistent diabetic macular edema or chronic persistent diabetic macular edema. For me, I want to understand what's these term meaning for the persistent and chronic persistence. When I go back to the literatures, they define the persistent diabetic macular edema, eyes with OCT, the central subfield thickness of 215 micron or greater at all completed. Yani after 5 injections, these patients never reach 250 despite he take at least 6 injections or 5 injections during the follow-up. These are called as a persistent diabetic macular edema. On the other side, what is the meaning by chronic persistent diabetic macular edema? It is the same as persistent. The eye does not achieve decrease in the subfoveal thickness of 215, plus they don't get a 10% reduction from the baseline or at least in the 2 visits, okay? So when I have these 2 conditions, the eyes does not achieve 215 and does not achieve 10% from the initial presentations, this is defined as a chronic persistent diabetic macular edema. So when I go back again, we see that persistent macular edema happened in all types of anti-VEGF. However, it's less about in the aflibercept in comparison to the Avastins. Why? We have to understand we have two pathology in the development of macular edema. First of all, it's the VEGF theory, and after that we have the inflammatory cytokines. So we have to consider other weapons in management of diabetic macular edema. So again, we see that many eyes does not resolve edema and regarding to protocol I and protocol T. This is the post-hoc analysis of them, and we see have so many cases of persistent diabetic macular edema. We have not to forget what weapons do we have. We have a laser, we have another types of anti-VEGF, pars plana and dexamethasone. We have to exclude other causes. So how to start treatment in these cases? Usually you have to consider about the visual acuity and the OCT, and we have two protocols to guide. It's protocol V and protocol T. The early response, ladies and gentlemen, the early response of the patients with diabetic macular edema after 3 injections, usually this is why we measure the response after 3 injections. 3 monthly injections of the anti-VEGF is usually associated with a 2 years outcome. So how we understand this is a good responders, continue on the same anti-VEGF, no stop if you have everything is good, and resume if you are worse. This is to summarize how to manage the cases of macular edema according to the protocol that we have. If you have a good vision, go for protocol V, not just observations, and the vision 612, you can go for protocol T, use any anti-VEGF, and if you have a worse vision like 615, go for aflibercept as the initial anti-VEGF that you have. So this is how to give the injections, and after, in your practice, usually we switch after 3 or 5. For me, I switch after 5. What are the switching rules? There is no any definition for switching rules in all protocols that we have. But the author suggested that if you have a cases of persistent OCT thickening and the patient does not achieve 10% of improvements, the vision is 24 or worse, and the patient does not gain 1 line gain of visions. So this is a criteria for switchings. Switch to what? According you start by Avastin or Lucentis, go for aflibercept. You start by aflibercept, go for dexamethasone, and you you have the 2 weapons, laser and pars plana vitrectomy. So I go back to my case, and we see the number here. So I start to switch to aflibercept, and this is after the first month and the second month, the patients get improving, and I will continue on the aflibercept. So regarding adding steroids, protocol you say that adding dexamethasone does not improve. However, in my practice, I see that adding steroids, especially the Ozurdex, have a very good result in maintaining the patients and improving the edema and improving the visual acuity. Finally, this diagrams, it's from my friend Dr. Amin Marashi. This is how to deal with the cases of persistent or refractory diabetic macular edema. Always search for other causes like epiretinal membranes, or if you have any focal leakage, go for laser. Don't forget to use the lasers, the pars plana vitrectomy, and other type of steroid. And again, finally, don't forget to control the ABC of the patients, the pressure, glucose, lipid, because everything's decreasing in the HbA1c, have improving in the development of the edema and everything. Thank you very much for your attention.
Thank you, Dr. Muhammad. It's a very nice case for persistent diabetic macular edema. And you told us that in your regimen, you switch from one anti-VEGF to another. If it doesn't work, you are going to switch to dexamethasone implant, right?
According to what I start. Yeah, I start by Avastin. Yes.
Okay, if you start by aflibercept, what are you going to do?
Steroid.
Steroid. You will not go to any other anti-VEGF?
No.
Because you consider aflibercept is a dual action, so
yes.
nothing else will work.
Yes.
So if the patient is pseudophakic from the beginning, this is for the audience. If the patient is pseudophakic and he tried 3 to 5 anti-VEGF, would you consider switching to steroids directly?
This is in a special consideration, Dr. Majdi, that we have, and the patient is pseudophakic, this is favorable, or something is you will attract you to give him steroid because he is already pseudophakic. So of course, the general status of the patients regarding the cataract, the IOP monitoring, it's other rules or criteria that you can bypass. You cannot start by Avastin, then shift to aflibercept. Aflibercept not good, go to steroid. If I have like these cases, no, of course I will go for steroid directly.
So again, it's a good message that a lot of people respond to anti-VEGF. Only 1 to 3% will have persistent diabetic macular edema, and we should not stop at this. We should switch and switch. And again, this is a very small percent, but sometimes you find it in your clinical practice, like persistent diabetic macular edema. You should not stop. You should try whatever you have in these cases. Last question, and I have an opinion in this, and I will hear the opinion of the panelists. Do you think vitrectomy will do anything in these cases?
Not
If
in
they
all.
don't have a parietal membrane, if they don't have anything at the vitreous interface?
As you said, if we don't have anything like no VMT and there is no the epiretinal membrane, some studies shows and some surgeons says that we may have a rules in the vitrectomy as at least you remove all the vitreous and replace, because the vitreous now are full with the VEGF material and any inflammatory markers, so maybe improving. But for my opinion, I don't think that's any rule of vitrectomy for the DME.
I've seen cases, and again, vitrectomy does not prevent the recurrence.
Yeah.
So again, it's a pathology. We have to treat that. We have to stick to it. Dr. Ibrahim, do you have any comment?
Just a few comments. Actually, we have to remember in diabetic macular edema, it is different from age-related macular degeneration. We have other options. And don't keep injecting, and switching from anti-VEGF to the other while you have another player, which is the steroid implants. And don't fear from the steroid that much. Simply, Protocol I gave you a guideline when to switch if after 3 injections, no response at all. I'm talking about aflibercept or Lucentis. In this case, you can switch early as that after 3 injections, as long as there is no response. Or even if there is slow response, you can carry up to 5 or 6 before you're switching. But intraocular steroid implants definitely can be considered as first line, even like what Dr. Magd said, in pseudophakic patient, in patient who had vitrectomy before, in pregnancy, for example, in other cases like patient who had a stroke or whatever, so they cannot take anti-VEGF. In these cases, always keep in mind that the steroid had a role. Second, Dr. Magd asked about vitrectomy. I think vitrectomy, it is a surgery at the end, and it's not a cost of price. Do the vitrectomy when there is an indication for vitrectomy, like epiretinal membrane or vitreomacular traction, for example, or any reason to do vitrectomy. But most of the people who did it just to remove the ILM and see if there is any benefit for this, it didn't show any benefits, and there is no need for it.
Thank you so much. Thank you, Dr. Muhammad. Thank you so much. My presentation is I think you can hear us well with this microphone, right? Okay, thank you. My presentation today is, it's not a tricky, but this is the title. If you pick early, that will save the vision. So what is this title? I don't have the presentation here, by the way. I don't have it here. Should I? This one? Okay, I will work from here. So this is a female patient, 17 years old. She is myopic, -6 diopters in both eyes, and look at the color fundus picture. She had right gradual diminution of vision 4 weeks ago with recent metamorphopsia in the right eye. And the best corrected visual acuity, as we can see, 636 and 6.6 in the left eye, and she had a tilted disc syndrome in the left eye also. This is her fundus picture. We can see a multifocal yellowish chorioretinal lesions localized mainly at the posterior pole and the peripapillary area. There is no detectable intraocular inflammation by biomicroscopy, and the left eye only tilted disc syndrome in a myopic fundus. So it's on initial visit on 2016. This is her fluorescein angiography showing early hyperfluorescence and late staining of the active lesion. We can see some of the lesions are active, some of them are atrophic, and we all know that PIC does this, which is punctate inner choroidopathy, and the atrophic lesion had transmitted fluorescence or a window defect, and it is not increasing in the later phases, but there is a juxtafoveal hyperfluorescent lesion which increases in size and intensity in the later phases, meaning that she is developing a CNV. Look at this CNV. Sometimes the CNV, in these cases, especially myopic ones, does not give you the full-blown picture of age-related. You don't have hemorrhage, you don't have exudation, you have a lesion which is increasing in size and intensity, which means there is a choroidal neovascular membrane. And this is, as I said, some of the atrophic lesions highlighted by the yellow circle, and some of the active lesion with staining at the very late stage of the fluorescein angiography, which means that this patient had previous attacks, and now she has a new attack of punctate inner choroidopathy. So it's an idiopathic inflammatory multifocal chorioretinopathy that predominantly affect young females, myopic patients. It's a well-circumscribed white spots. We see it at the posterior pole. Sometimes we think it's a multifocal choroiditis. It's one of the spectrum, but it's specific for these cases. And it's punctate lesions, and there is no obvious signs of inflammation, either in the vitreous or in the retina. And there is marked visual impairment, which brings the patient in when they develop CNV, as in these cases, when she came with metamorphopsia 636 vision. And this is her OCT angiography, which is very helpful in this case, as I'm going to show you in the rest of the case. So focal elevation of the RPE, this is the typical characteristic in OCT. Focal elevation of the RPE because the lesion is under the RPE. Presence of sub-RPE hyperreflective deposits, as we can see here. And focal atrophy in the outer retina RPE, where the atrophic lesions is. And look at the OCT down there, focal elevation. And this is the CNV in the macula with overlying retinal edema. But some of the punctate lesions are atrophic, some of them are active. And when you see active lesion, you see elevated RPE with sometimes, as we will see, hyperreflective foci under the retina in the choroid, which means the lesion is at the level of the choroid. And as we said, it can be easily complicated by CNV. By the way, this is the other eye at the time of presentation, 2016. It's crystal clear, nothing in there, and tilted disc syndrome, and the vision is 6/6. So this is the initial presentation, and this is 2 anti-VEGF. She is responding well, and regression of the edema overlying the CNV. We all know that CNV will never vanish or disappear, but sometimes it regress, and it leaves like a small hyperreflective lesion like this. And OCTA proved there is no activity in this eye. 3 months later, after recurrent activity, because in these cases we inject PRN. We don't have protocol for this like neovascular AMD, so we inject PRN until the CNV is quiet, and we stop injecting. 3 months later, she developed another metamorphopsia. We can see the fluid. We can see minimal subretinal fluid. We can see recurrent activity of the lesion. And again, OCT angiography can show us the flow with the density map and the flow inside the CNV. Another 2 anti-VEGF. She gets better, but as you see, the scar is getting larger, and probably it will affect some of the vision. But again, the patient were quiet after that. And look at this 1 year later. Of the left eye. She came with small punctate lesions in the left eye. This patient came complaining of the left eye, the right eye was stable, and 6/9 vision, and I looked at the outer retinal layers, and look at this. Some of the elevation at the level of the retinal pigment epithelium, some of the like fragmentation of the photoreceptor layer, and I looked at this is the red arrows, and a magnified picture showing you something is going on, and look at the choroid. Multiple hyperreflective foci inside the inner choroidal layers, which means the inflammation is starting in this eye. And this is a wide field OCTA and on-fast OCT, and it shows the punctate lesion, which is not clearly seen on the color picture, but multiple punctate lesion, which is an active lesion, and I keep following up this patient. And I asked myself, should I give something? I used to give them systemic immunosuppressive for this patient because it's in the literature. It can halt the disease or stop the progression. But 2 months later, visual acuity decreased to 6/12, which is 1 more line, and the patient is complaining of diminution of vision. And I can see parafoveal disruption of the ellipsoid zone, which is very obvious in the OCT down there, and there is defect in the retinal pigment epithelium. And I looked at her, and I looked at the OCTA, there was nothing in there. So again, 2 months later, she had multiple subfoveal lesions, as we can see here, which looks like a pick, but the patient is complaining of metamorphopsia. Don't fed up and do OCTA. I found a very tiny choroidal neovascular membrane, which I think I catch it very early because it starts to penetrate through the defect in the retinal pigment epithelium, and we can see it crystal clear here. There is a choroidal neovascular membrane clearly delineated by OCTA, but it is not seen clearly by the OCT. And 2 intravitreal anti-VEGF injection, we can see complete regression, or almost 90% regression, and the vision regains 6/9 vision. And I was happy to catch that very early and catch it. And this is left eye 2 years later. It needed only 2 injections. She kept 6/9 vision. And we can see that the right eye also kept stable for 6/12 vision because I didn't catch her early. So my take-home message is PIC, or punctate inner choroidopathy, is an idiopathic inflammatory multifocal chorioretinopathy that predominantly affect young myopic females, and severe visual loss can only result from CNV. And distinguishing active inflammatory lesion from CNV, it's very important using multimodal image, and OCTA is one of the crucial things in there because you can pick the complication of PIC very early. Thank you so much.
Thank you,
ready
Dr.
for the
Magdi, for this
question.
case, actually. But forgive me for my ignorance for uveitis cases. But anyway, for the left eye, when you started to see these early signs and the persistent inflammatory granules, which is there, or whatever, will you treat the PIC itself before the subretinal neovascular membrane develops, or what?
Yes, I
mean,
did.
Usually they give steroids or
No, in the literature, they say steroids and immunosuppressive. And I used very low dose of steroids and immunosuppressive, but this did not prevent the happen of CNV. This is the trick. You can treat them to prevent the progression, but sometimes it does not prevent the complication because once any defect happens in the RPE, they start to trigger the CNV. So this is a very important thing using OCTA when you have a complaint and you cannot explain that complaint by the patient, and you find out that sometimes respect the patient complaint and finding the CNV, that would be crucial to save the vision very early. So if you pick it early, you can treat it early and you can save it.
And the results will be better. And so simply you treat the PIC and keep an eye when this membrane will come and just give the vision.
OCT and OCTA is a revolution in retinal management because you never expect that this tiny lesion can turn into CNV in the macular area.
Thank you very much, Dr. Majdi, for very nice case presentations. But I would like to ask, in the cases of CNV, because usually in my country we don't face too much cases of CNV. The management of CNV, you said you give the anti-VEGF and we see the stabilization of this patient after anti-VEGF. Is any recommendation for any anti-VEGF to start with treatment? And also we have switching rules when you start by one anti-VEGF, then you switch after no response. So just to illustrate
that's a good one, and because we have a scientific session, not pushed by any companies. This is a very good question. You use Avastin in your country.
Yes.
I use Avastin. I still use Avastin. Avastin is my first choice. If it doesn't respond, I switch to another one. But the message here, and this is a good question, secondary CNV. Secondary CNV does behave completely different from neovascular AMD. Secondary CNV, you will never know when they respond, how long they keep injecting. So try PRN from the beginning. One injection could solve the problem. One injection. So try one, do an OCT, another one. If it's stable, follow up monthly by OCT. And I also do OCTA when I suspect that there is a residual activity. But OCT is quite good enough, and follow up monthly by OCT is quite good enough. PRN is the choice in this cases, secondary CNVs. And once you have complete regression, vision is stable in the last two injections, you should stop the injection.
For how long PRN? Yani 4 months?
Monthly.
Monthly?
Monthly PRN until complete resolution of the CNV. And after that, follow up monthly by OCT. If recurrence happens, monthly again. I never use loading dose because, as you have seen, 2 injection was quite good enough. 3 months again, 2 injection, and then 2 years, there's no recurrence. And the left eye, only 2 injections for 2 years, nothing happens. So you will never know how they respond because we don't have randomized trial for these cases. So secondary CNV is a dilemma, but again, you should stop that.
Thank you.
Thank you so much. Present the next.
Now I would like to invite Dr. Ahmed Al-Barki. Ahmed Al-Barki.
Assalamu alaikum. Okay, thank you so much. Thank you for Dr. Al-Amri for inviting me today, and thank you to the panelists. I'm going to share a case today. I will not say it's a difficult case, but somehow interesting case. I don't know if you see the same like this or not. Can you see play my position, please?
Use the advancer.
ما أنا use معهم. Nothing.
طب حطوا عليهم كده وجهوا ناحيتهم. معلش عشان انت بنتكلم يعني. Yes. And the laser pointer now, they will.
It's not working, sorry.
It will work. Give them some time. There is a lag between.
There is a delay? Okay.
Delay between you and between all the presenter and them. It's coming.
That's something from them.
Coming.
It's a technical issue.
Take a deep breath and pray, and they would come. You see?
This is not the first slide. Can you give the first slide, please? Yes. Yes, one more. First slide, boss. Wait. Okay. Okay. So this case is the male patient, 9 years old, diabetic, cardiac hypertension, coming just regular up in the clinic. So an examination, that first visit was vision is okay. IOL in both eyes, small draws in OU, nothing to be worried about. So when we do OCT for him, you can see here, this is the right eye, just a few RB changed there, and the left eye, a few druid in there. So usually we give follow-up with this patient every 3 months. The next visit, 6 months later, he was not complaining of anything, but in visual acuity, it was a bit blurred or decreased vision in the left eye, but the patient denied that. Normal IOP, everything is okay. So when we did OCT for him, you can find here the small cystic changes with hyperreflective dots in the left eye, temporal to the fovea, and there is interretinal edema also. So we discussed with the patient that we need to start the treatment, but the patient or do focal laser based on fluorescein angiography later on, but the patient refused the idea because he don't want any injection. He said, let's control my blood sugar and follow up monthly. Okay, we said decide follow up monthly was advised, and let's see what's going on. And as expected for sure, because if you just kind of patient need to start the treatment early, and that's what explained to the patient, but he didn't want to do the injection. So next month, he come blurry vision in the left eye. Now he's complaining of blurry vision in the left eye, and the vision dropped to 20/40. And if you do the OCT, now you can see the edema increased. So the small cystic change become bigger cyst and hyperreflective dots there. At that time, he agreed to get the injection. So we start with the intravitreal anti-VEGF. We start with ranibizumab, and we give him 3, this is after the first month. But I want to highlight here something. If you look here, this is a small changes start to happen at the RPE with some drusen there. So this should be keep in mind. And this is after the second month, getting better. And after 3 monthly injection, almost dry, vision came back to pre-injection level. So at that time, we discussed with the patient, okay, let's go treat and extend, because we are expecting to recur again. But again, the patient was not happy to get any injection. So since he's okay now, he refused any injection. I said, okay, let's go for monthly follow-up to check what happened. So 6 months later, he was doing well. And you can see here, start here some more changes at the level of RPE with some drop in there. Vision a bit, dropped a little bit, but the patient does not complain about it. So, but 4 months later, he came starting this activity. We have some hyperreflective space here with choroidal vascular membrane, subretinal fluid, sub-RPE fluid, and the vision dropped. So the plan now is to do for intravitreal injection again. I explained for him this different pathology now. We give him 3 monthly injection, but not too much response. You can see just reorganizing the fluid, but still fluid there, and we have what we call some hyperreflective deposit under the macula. So we give another switch at that time because I consider it poor responder after 3 monthly injection, no change in the OCT and no change in the vision. This is poor responder. I am early switcher. So I switched to aflibercept, 3 monthly injection followed by monthly as per label. After 3 monthly injection, the same, no change. There might be a fluid decrease a bit, but the vision is the same. And the hyperreflective material or shrimp increase. You can see here, it's getting a bit bigger in size. 1 month later, during the loading dose of the aflibercept, as you give 3 monthly injection and every 2 months. So during the loading dose, actually, this was interesting. He came with this picture after 3 monthly injection of aflibercept. So this is mean 4 months now. Very huge subretinal and extensive size of shrimp. So, and vision dropped too much. So at that time, I don't know what's happening, why this happened. The first thing to come to my mind that could be from the drug tachyphylaxis or something, so I need to change another molecule. At that time, we have brolucizumab available, so I did OCTA before that to make sure that we have some tuft there. So we give him brolucizumab as a new molecule. Actually, 1 month, it was very good response in terms of drying, but the vision does not improve a lot, and the shrimp is still there on both sides of the fovea and the retina. So the vision does not improve too much. This is after the second injection, same. Third injection, 1 month, vision improved a little, still the shrimp there. Let's compare between the pre and post injection of brolucizumab to check for the comparing the size of the shrimp before and after. I cannot say it's something obvious. I mean, you can see some decrease in the thickness, and that's why make me go and review the literature about this, what to do in this case. And maybe my question to the panelists after I finish my case, I go through it. I find we know now that the shrimp have a poor prognosis for the visual acuity. We all know that. But is there any way to treat that? So I go for the post-hoc analysis of Hook and Harrier. I think you were about the brolucizumab. And in this study, they check the effects of brolucizumab on the thickness of the shrimp, either at the fovea or parafoveal area. And they found that some have some response, which I didn't see in my case. And this is my second question to the panelists. Have you seen any improvement when doing such a shrimp, or what you are doing to do in this case? What are you going to tell the patient, because the vision is not improved, no fluid, and what to do next? Thank you so much.
Shukran, Dr. Ahmed. Thank you so much. This is a nice case, but it's a double pathology, as you said. Shrimp is a combination of many things, which is hemorrhage, exudation, subretinal fluid, and when they amalgam, they do that. Shrimp is bad prognostic sign anyway, because shrimp already, all the outer retinal layers are destroyed, and there is no way to regain this. So your task is to dry the macula. And once the macula is dry, forget about the shrimp. You can do nothing for that, because it was amazing that first injection and complete regression of the fluid, and this is your task. Exactly. Nothing else you can do. Once the shrimp is in the foveal area, all the outer retina is destroyed. So if this patient got recurrence, he will have a marked diminution of vision, and you are going to fight to regain the 660 vision. So shrimp is nothing to be done.
That's my point. My second point is, did you see any evidence or any effect from the anti-VEGF on the thickness of the shrimp as per this study, or that's my point, because I think with
time, this thing, like any scar, at the beginning, the scar will have many components, but it will regress a little bit. But even though you will have foveal destruction of the outer retinal layers, so don't run after that. Just inject till the macula is dry. Treat and extend is better in these cases. You should not wait for the recurrence. If you waited for the recurrence, that will be marked diminution of vision.
So you don't treating the shrimp, just follow up. Any other thoughts?
Actually, hi, thank you for the interesting case, but just two things actually. Did you think about PCV in this case? What I mean, ICG here can be done or whatever, because usually when this happens, there is
usually, in PCV, what I've seen or what I've learned, we have huge or large RPE detachment. Usually it's like polyp there, and also the OCTA, it show a typical or something there, so it could be. But yes, I agree, it could be there, but the question is,
the ICG here,
if it is PCV, I mean, also the PCV, as I understand, as I remember, the incidence of shrimp after PCV is not common like the age-18 macular with age. The second thing is, does it change the treatment if it is PCV? That's my point, because we don't have actually now the Visidyne if you want to do.
The main reason for asking this question for PCV, because I have a similar experience where you have a PCV, and definitely if I'm going to believe in one anti-VEGF at this stage, not because forget about the companies or whatever, brolucizumab made the difference. I can show a couple of cases where you used everything you can, and suddenly when you switch it to this drug, when it's available in the market, it's completely different drug from one drug only. And and I think there was a big dilemma about the intraocular inflammation, which prohibited people from using the drug, which will be suitable for a lot of patients actually, rather than leaving the retina to be destroyed by this way. Okay, this is one thing. So thank you for mentioning the brolucizumab.
No, that's okay.
By the way, if you look at your OCT, it was a good one, OCTA, but it's a PCV, because on the OCTA, if you look at it carefully, it's a branching vascular network.
Yes.
You could not see the polyp, but it's a branching vascular network because it has been injected many times. This is
because we didn't do OCT at the because it's not available at that time.
The trick is, if you don't have ICG and you do OCTA in a huge elevation, you will never catch the polyp. But after regression, do an OCTA, remove the artifacts, you will find a very nice branching vascular network. It's a CNV, but it's a kind of CNV.
I know, BCV,
branching vascular network with a very tiny polyps at the end. So your OCTA was great, but it has a branching vascular network. So it could again be a PCV, and that's why it's responded very rapidly.
At the initial presentation, it was not looks like PCV, because PCV have a characteristic, in the early beginning of the OCT, you find this huge RPE. It should be there is RPE detachment.
Not all the cases. Sometimes you have
most commonly
multiple double humps or 3 humps, and this is the PCV.
But in this case, there is no RPE at all. It's all subretinal. That's why we didn't.
I would not argue about that. I agree with you.
That's very
good.
You. Okay, thank you so much.
Next presentation by Dr. Ibrahim Al-Gharabli, and the first presentation to have a title It's called snow blindness. Please, Dr.
Actually,
Bennett.
don't let the title misguide you for whatever coming. But anyway, it's a 74 years old lady. She had bilateral phaco plus IOL. Vision was 6.5 in both eyes, absolutely perfect. And then a few months later, she was referred to her optician, decreased vision to 6.15 in the right eye compared to 6.6 in the other eye. And they said there is some sort of capsular opacification. Let's do EEG, and then discharged her. Re-referred again from the optician to our department, wrinkling, network, and the vision in both eyes. That's what she mentioned. 6-well best corrected for both eyes from 6.5, remember, after the surgery. And when you do everything, Amsler fundoscopy, you couldn't find anything. It's normal. So the first time I saw her, it was at this stage, increasing visual difficulty. That's her complaint, just a little bit of detail of the complaint. Snowstorm effect in the vision, that's what she described. Reduced peripheral field after more problems in the dim light and in the dark. And at this stage, when you ask the site of pathology, you are talking about roads, something happening in the peripheral retina by way or another. And her past medical history, she had removal of melanoma from 3 years ago, and family history nil, and she is fit, and otherwise no problems with her. So in examination, the vision was 6.36 in the right eye, 6.18 in the left, 6.12, 6 hours correction. She had constricted fields to confrontation, and bilateral IOL is normal, and fundus are normal. And you looked at fundus, there is nothing in the fundus examination at all, okay? And in this case, at this stage, will you put any diagnosis for this case? Anyone want to put any differential? And what kind of investigation came to my mind at this stage? Field and ERG would be done for a case like this, and I wish if you can tell why I asked for those specifically. Simply, that is her visual field, constricted visual field from her symptoms. On the other hand, that is the ERG, if anyone wants to comment exactly what we're seeing here. What we are seeing here, the photopic ERG and flickering ERG, which reflecting the cone function are normal. However, the scotopic ERG, there is no B wave, only A wave, and that's what we call it negative ERG. Okay? Anyone can give the diagnosis straightforward now? It is, yes, it is melanoma-associated retinopathy. And unfortunately, for cases like this, there is no treatment possible. And she was referred to melanoma nurse, advised to stop driving, and she was referred to Morpheus for second opinion. They did CT head for this lady and CT chest. They found the axillary shadow, and they repeated the chest X-ray later, and still the shadow there. So they decided to go for axillary exfoliation, removed 14 lymph nodes, and 4 of them have been positive for melanoma, which means she had the metastasis at this stage. The diagnosis confirmed, of course, no treatment. 1 year later, still symptomatic, worse in dark, 6.36 vision. The vision didn't change that much compared to what I saw her, and she had low vision aid, and of course, unfortunately, she had a certificate of vision impairment. So what's paraneoplastic disorders or eye disorders? Simply, there's 2 groups: autoimmune retinopathy, when there is no tumor at all detected, and there is the paraneoplastic retinopathy, which is CAR, cancer-associated retinopathy. Any type of tumor could be associated with this type of retinopathy, or melanoma-associated retinopathy. This is the case. Or it could be represented as neuropathy, what I mean, the optic nerve. And CAR is the most aggressive and subacute case of them, because simply the patient will lose the vision because it is directed to one of the proteins which are present in the cone center of vision. Melanoma-associated retinopathy, there was a dilemma in the literature until it is classified as paraneoplastic retinopathy in 1988 by Bresson. And the antibody which was formed, there is mismatch between antibody formed against one of the antigen of the melanoma and the bipolar cells in the retina, and this is why these antibodies attack the bipolar cells in the retina, preventing the transmission to the inner retinal layer, and this will lead to the severe defects of magnocellular pathway with sparing of parafoveal pathway. And the symptoms will be root dysfunction, like what the lady presented here, peripheral field constriction, and difficulty in seeing in dim light, and etc. Actually, they usually have what's called entoptic phenomena, and that's what the lady described here by snow coming in front of her or whatever, and it could be any of the entoptic phenomena for her description. There is big differences between carcinoma-associated retinopathy and melanoma-associated retinopathy. The main ones are, in MAR, it is only rods and are affected. Commonly present after the melanoma is diagnosed. More common in men, and near normal visual acuity, color vision, and central visual field will remain till late, and often doesn't develop progression of the retinal dysfunction. So they stay stable for a longer time compared to the carcinoma-associated retinopathy. How we diagnose it? It's simply, as I say, positive history of malignancy. History is a key. Second, you need to demonstrate circulating immunoglobulin antibody. What does mean? There is two antibodies specifically, aldase A and aldase C. You can diagnose them with some serum tests, immunohistochemistry, and even Western blot as well. And ERG is diagnostic because this is one of the cases with negative ERG. Can anyone remember what's the negative other cases for negative ERG? If I can recall some of them, one of them is central retinal artery occlusion, and the other one is the congenital stationary light blindness as well, and retinoschisis. These are the 3 or 4 cases where you have negative RG, there is no P at all. And this is how to present, and the visual field, of course, reconstruction. Differential diagnosis, these are the cases, as we mentioned, and the management overall prognosis, unfortunately, is not good. Surgery tried, chemotherapy, they tried immunosuppressive treatment, but nothing is working in these cases. And if I going to mention one other diagnostic thing as well, these patients have usually positive family history of autoimmune disorders. Anyway, in conclusion, paraneoplastic eye disease disorder present only part of the spectrum of autoimmune retinopathies. Neuropathies have been better visual prognosis compared to retinopathies, maintaining high index of suspicion. The most important here is not to save the eye only. You can save the life of this patient if you reach the diagnosis, like this lady which had metastasis and no one knows about her. And then they started to take this and give the immune chemotherapy. Thank you very much for your listening.
Thank you, Dr. Ibrahim. It's a very good case with a message. My comment is some of these cases had a very positive family history for autoimmune disease.
Yes.
So once you find a case with an autoimmune disease like this, probably the history of the family, because it doesn't happen to most of the patients, but once they have a positive history for autoimmune disease, that can happen because we all know this is antibodies against the retinal pigmentation and the pigment inside the body. So again, it's a message. You should respect the patient complaint. You should do whatever you do, and the best investigation you did is field of vision and electrophysiology. This is diagnostic. Nothing else will be diagnostic because nothing can be seen on fundus or fluorescein or OCT in these cases. But once you diagnose these cases, you avoid further and further investigation for these patients.
You're absolutely right, Dr. Magdi. Simply, it is the suspicion. History. Taking good history can give you a clue because this lady has been seen by 2 or 3 persons before, but no one picked up that she had melanoma before.
Yes.
And then when you listen to the melanoma 3 years, here you start to think what's coming. So history is a key.
Very important.
Exactly. And on the other hand, as you said, family history, because autoimmune disorders in the family can raise a suspicion toward the diagnosis of the case, and it will direct you which kind of investigation you need to confirm or exclude the diagnosis in these cases. Thank you.
Thank you so much. I'm sorry we have to run for the next because we are running out of time. So next presentation is by Dr. Muhammad El-Azazi, another mysterious case presentation from Saudi Arabia, or is it outside Saudi Arabia? Special for me? Okay, thank you. He took it with him.
So good afternoon, everyone. Thank you, Dr. Amri, for making this happening. Thank you for the panelists. So today, I will share with you a very short presentation about one case of mine. So this is an 80-year-old female. She is non-diabetic and hypertensive. She has a colon cancer treated long time ago, 20 years ago, and she's in remission. All of her exam is unremarkable, good vision, except for the I can say where is the... it's not working. Okay. So the only thing is the hard disk dates that you can see in the midway between the disk and the fovea. And this is her baseline investigation. So at the beginning, we just thought that this is only pre-papillary choroidal vascular membrane, good OCT, good vision, no intervention at this point. So we elected to just give a point, like 1 month follow-up. She came back with, now with decreased visual acuity, exudation is more, subretinal fluid is more, and vision dropped. Now we decided to start the treatment. So anti-VEGF on monthly basis, ranibizumab at the first. And this is here after 3 monthly ranibizumab. The exudation is increased, the fluid is increasing, and the vision dropped even further. So now what is next? Yes, the initial diagnosis is pre-papillary choroidal vascular membrane, but she is not responding. And we actually, if you look at the at her OCT, nothing else can give you any clue about, let's say, a BCV. So we shifted her to aflibercept, and this is her after 3 monthly injection of aflibercept. Vision kept to deteriorate more, and she is not interested in any more treatment. Now, this is the typical finding of OCT in BCV. You can see the thumb-like polyps. You can see the demographic notch in BD. You can see the hyperreflective lumen surrounded by a hyperreflective ring. And you see the double layer sign. None of this is existing except the thickened choroid. So this is our case. And if you see this area close to the disc, it looks like a big cyst surrounding the area, and it is the source of the leakage. We decided to do ICG just to make sure that we are not missing anything. And you can see very clearly multiple polyps are just shown in the area temporal to the optic nerve, and it is in the papillomacular bundle. At that time, there were no Visudyne available. So what is next? We decided to go for ICG-guided focal laser to the lesions after discussing with the patient the possibility that she may lose her vision because it's exactly on the bundles. The other thing that in polyps, it's not like focal laser for a lesion that you need to go with a very long duration, sometimes exceeding 250 milliseconds, reaching up to 400 milliseconds to treat those lesions. So this is here 1 month. You can see the lesions slightly start to flatten. The exudation at the photo on the left side, if you compare to the previous one, it is slightly less density. So we decided to go for another session, and this time we also combined the laser with another monthly injection of aflibercept. So this is here. You can see the density is less if you compare it with the previous one. The intraretinal lipid deposition is much less. We kept her only after the second session on monthly anti-VEGF treatment. And you can see the progression until she reached, her vision reached last visit, which was mid of September. She reached 20/30 from 2400. Now, I think we need just to highlight what is the purpose of changing sometime your technique just to get a better result. So this, I found it in one of the papers describing the best treatment for juxtapapillary lesions, that if the patient is symptomatic and there is an active lesion, thermal laser along with the anti-VEGF is the best treatment for those patients. If it is active and asymptomatic, this will be left to the physician discretion, and quiescent BCV usually observed. Everest trial showed also combined treatment usually superior in the outcome of the polyp closure and the best corrective visual acuity, and also in Everest 2, it showed also higher proportion with absence of the disease over 12 months. This is a flow chart showing the best way of treating some of the BCV lesions, and this will lead to my conclusion. So ICG is still the gold standard in the diagnosis of BCV lesions. In the absence of Visiodine, combined argon laser with intravitreal anti-VEGF injection helps in decreasing the exudation and result in stabilization of the disease and improvement of the visual acuity. Combination therapy may reduce the need for treatment in BCV patients. Thank you.
Thank you very much for this case. Actually, just I have a small comment. As you mentioned, BCV definitely can have. BCV could be one of the diseases which is very resistant to treatment in some cases, to be honest. Okay, and as you say, you try injections and it's not working. But one of the new player which has not been mentioned here now is brolozumab, and to start to use it in these cases, you will see a big difference. That's one thing. The other thing, as you said, BDT is not available everywhere, so I liked your approach when you said, yes, we can use other things like focal laser. But here, maybe the site of the lesion helped you to do the focal because it's away from the fovea. But when it comes to closer to the fovea, it will be difficult to do any focal laser, of course. BDT giving is still one of the gold standards for cases like this, again, without doubt, and the combination, as you mentioned, is the key. So thank you for that. But brolozumab will be a good option, I think.
Thank you very much. The prepapillary pachychoroid lesions are very hard to treat indeed. Focal laser was a very great option for this treatment, but what would you do if it was under the bundle, the RNFL bundle? I think it will be very dangerous to treat with the focal laser.
Can you answer that?
Yes,
I don't think it will be difficult to treat. I think killing the enemy instead of waiting for the macula to be destroyed. Even if you have a scotoma in the papillomacular bundle, it will save the macula. So again, sometimes laser photocoagulation is inevitable. The only thing I regret here is that you stopped injection. You started anti-VEGF, you switch it to another anti-VEGF. You should not stop injection because you are treating the consequence. I see that the fluid did not go away, but you should not have stopped injection. A good idea using laser photocoagulation, it's a very good idea. As we said, it's away from the macula, even in the papillomacular bundle, sometimes I would not hesitate because as Dr. Al-Gharabli said, it's not a CNV, it's a polypoidal. So in the polypoidal, you don't need a very high power, you just burn the lesion and it's ICG guided. Even in the papillomacular bundle, I think it would have worked and you can do once or twice if you don't need to increase the power. But again, leaving the patient with a paracentral scotoma instead of leaving the patient with macular
Actually,
loss.
the answer came from the patient herself. She said, Doctor, I don't have anything more to lose.
Yes.
I'm already 2400. So
yes.
What worse can happen? So just go ahead with whatever treatment
2060 or 2080 with a paracentral scotoma is better than 2400
yes.
without
she
the
reached
scotoma.
2030.
And I see Dr. Ibrahim is very fan of brolucizumab.
Yes.
So next time, use brolucizumab and tell him what happens.
One day I'm going to show the spectrum of cases that I have where the brolozumab made a difference. You see people have 8 injections of Eylea and Lucentis or whatever and the whole thing, and will you think, okay, there is any point to switch from anti-VEGF to the other? I can show, yeah, there is, if you have drug like this, but because many of you didn't use it yet, I really just encourage you to use it. Don't be worried about the intraocular inflammation because we are saving the central retina here.
This case came before the introduction of, yes, it was 2019.
Yeah.
Unless if you have something in your warehouse at that
and
time.
I agree with Dr. Magdi for the papillomacular bundle, no problem. Remember that when we hit the laser, we hit it at the RBE level, okay?
Yes.
And in this case, sometimes even the patient doesn't have scotoma. Remember how many patients of CSR where we treated the patients near the macula and they don't have any problem as long as the fluid is down. So it's not an issue.
Okay.
Thank you, Dr. Hazazi. We are running out of time, but thanks again for this debatable case. Let's invite Dr. Subard Jalili, who had the case presentation, please. احنا متأخرين
Okay, so this is a case which I have seen only once in my life. Hello. So I've been treating ROP for almost 30 years now, and this is the only case I saw where this 1-month female child came to us. She had a stomy course. She was not a very tiny baby. She was 35 weeks, 1.6 kg. Normally a 35-week baby would be about 1.7, 1.8. She was a little low. Her mother had no infections, and her mother was a diabetic. And she had been in the NICU, had received transfusions, seizures, and had antibiotics for 15 days, oxygen for 15 days. So when she came to us, we did not photograph her at that time. My fellow did a beautiful drawing showing that she had threshold ROP. Later we took her right eye picture and that the left eye was similar. And you can see here that there were areas of stage 3 and there was some hemorrhage in the lower part. Here you can see that. And so we decided to laser, and my fellow who had done about 20 lasers started doing the laser, and I'm in the OPD, and then he comes to me after laser and says, should I laser on the hemorrhages? I said, there are no hemorrhages in the retina. He said, no, there are so many hemorrhages. So I was like, there are no hemorrhages. Actually, there was only one hemorrhage. He said, no, there are so many hemorrhages in the retina, and you can see, this is while doing laser. My first thing was like, you're the first doctor in the world to see a CRVO developing while you are doing the laser. So I was very curious to know, how did the hemorrhage start? Did it start at the disc? Did all the vessels come together? What happened? He had no clue. He said, oh, I didn't realize that this child has developed CRVO while doing the laser. So, we were in great dilemma. The baby's there, and he's just done about 2,000 spots. And there seems to be an arterial narrowing and a venous occlusion right there at that particular time. So lots of things go into your mind, like what are you going to do with this baby now? And then she has the other eye. This goes upside down. Okay, so my first thing was like, I have to think, because Harry has not taught me this, ROP society has not taught me this. I go back to my MBBS to Varsho's triad and try to think, maybe the fellow was putting too much of pressure on the eye, and it caused that CRVO because of the intraocular pressure. But then he had completed the laser, so then he could not have put that much pressure, because to complete laser all around, he had to release the pressure. And that was very unusual. Then I thought maybe somebody has put too much of phenylephrine in the baby, and we checked her BP, pulse rate, they were normal, so it was not a systemic hypertension. We thought maybe she's dehydrated, and that's why she got that CRVO, but she was fed well. Then we thought maybe she had some thrombotic tendency. Now the immediate thing was, should I inject or should I not inject? Baby has developed CRVO. Here, the CVO study is not going to help me. I cannot do gonioscopy and NVI check and RAPD check and field check every month. So I have to make a decision, should I inject or not inject? But most important question was now, should I laser the other eye or not? My concern was that if this eye goes into neovascular glaucoma and doesn't see anything, then the parents will not be ready for the other eye laser. So I had to take the difficult decision of going ahead and doing the laser right away without informing the parents that one eye has developed CVO. So they had given consent for both eyes. I went ahead and did the laser myself. A lot of concern that, will my laser cause CVO in the other eye? But anyway, I finished the laser, handed over the baby, explained to them that there is a hemorrhage in the other eye and we need to investigate for any systemic hematology abnormality. And the patient came after 2 days, so that was being done on a Saturday. Patient came on Monday, and you can see what happened to the eye. Within 24 to 36 hours, you can see the things have worsened. The vessels have become much more arterial narrowing without any intervention, and so the disease is progressing. And that is one lesson we learned, that when the vascular occlusion occurs, after that the VEGF is released, and it leads to further loss of the function over the next few hours. So it's a rapidly progressive condition. So on that day, we had no choice, so we went ahead and gave Avastin to the affected eye. And then after 2 days, we also had, got the reports. We wanted to rule out any intracranial hemorrhage in the child because she had so much of CRVO, and we also got other thrombin done, and we were at least lucky to find the cause. The baby had protein C deficiency, and there are two types of protein C deficiency in neonates. They can either be genetic because of factor V mutation, which she did not have, or we learned for the first time that sepsis can cause an acquired protein C deficiency, and there's a treatment for it. You give fresh frozen plasma, and it will reverse. There are reports of renal vein occlusion and CNS hemorrhages and thrombosis in the CNS in babies who develop protein C deficiency, but there are no reports of retinal vein occlusion. There's one report of retinal vein with renal vein occlusion in a similar situation, but all these were spontaneous. So I presume that maybe there are more babies who develop this type of occlusion, but because it will be asymptomatic, it will not be picked up in the acute phase of thrombosis. And then, over a period of time, everything resolved. You can see within 2 days of the anti-VEGF, the whole CRVO has gone. And that was very gratifying, and then all the areas which were left unlasered, we could go in and do. So the anti-VEGF had a very dramatic effect on the CRVO in this neonate within 24 to 48 hours. And the CRVO completely went away, except there was a small hemorrhage over the fovea. And finally, now at 4 years of age, her vision is 20/30 in the right eye and 20/60 in the left eye. She's on patching therapy right from the time that we injected the anti-VEGF. So what are the things I learned? I think the basic sciences and researchers, my salute to them. They do a tremendous work. It was Varsha who came to my rescue in this dire situation, which is once in a lifetime situation. The CRVO will evolve into a more severe state with every passing day. So to cut short that attack, we must inject immediately. And that is my practice in adults also. We don't wait for some natural history to reduce. If there's a vascular occlusion, inject immediately. It will have a very dramatic effect, and the whole thing can resolve very quickly, not needing multiple injections. This baby needed only one injection, single injection, within 48 hours, and everything cleared off. And I think some babies may be suffering silent CRVOs. We may not know because there's no clue. And of course, we do see sometimes children who come at 5, 6 years of age with a disc pallor, with an old occlusion, and we don't know what's the cause, and they may be having a protein C deficiency. So I think it's very important to know your case in detail. In this particular patient, the neonatal sepsis was the cause. Many times we don't give importance to neonatal sepsis because that has been taken care of by the pediatrician with antibiotics, so it is of no concern to us. But here it was the sepsis which led us to the protein C deficiency. So I think, we thought the size gone. It looked like this tree, which we transplanted in our center. It looked like a dead tree, but actually it flourished very well. Thank you so much.
Thank you so much for this interesting case, but I'm sorry we have to shut down the discussion because we still have 2 presentations and we are running out of time, and I can see the cornea people are coming in very slowly, very slightly. So let's go to the next presentation. شكرين دكتور طارق على التلميح. شكرين جدا حضرتك. ماشي هنخلص. Can we invite the next presentation, Dr. Noura Al-Mansouri, please. I'm sorry for the running out of time, but I'm sure we will listen to you, and Dr. Muhammad Awadallah, because Dr. Tariq Athamish will never stop you. So I'm glad that you are the last one.
Good afternoon, everybody. My case is short and sweet, so I know.
Thank you so much.
Don't worry, I made it already short. So my name is Dr. Noura Al-Mansouri. I'm consultant ophthalmologist, vitreoretinal surgeon, Samaya, Abu Dhabi. So my topic is about secondary epiretinal membrane. So she's a 20-year-old female complained of blurry vision in her left eye, and her vision was 20/25. IOP is normal anterior segment. She was seen already by another ophthalmologist, and she came to me for a second opinion or any treatment can be offered for her left eye. And this is my OCT. So my question to the panelist. So this is an OCT of epiretinal membrane. What is the differential diagnosis for this case? We can start with Dr. Majdi. Yes, I'm questioning you now.
Epiretinal membrane differential diagnosis is, but it could be inflammatory, it could be traumatic, it could be old lesion, it could be resolved with macular edema, a lot of trauma. I mean, anything can lead to epiretinal membrane, especially if the other eye is free, right?
The other eye is absolutely normal and completely normal.
Okay.
So it's unilateral.
Thickened posterior hyaloid can give you this kind of OCT.
She is not myopic. She's not suffering from any
Nothing.
systemic disease or anything else.
She's absolutely healthy.
Okay, go ahead.
So that's why I think we have to rule out secondary causes of epiretinal membrane. Not every epiretinal membrane is idiopathic. Like Dr. Majdi said, we have to rule out other secondary causes. And this is a dilated fundus exam of her eye. So what do you think?
We have peripheral ischemia, we have new vascularization. It could be Coates-like disease, peripheral telangiectasia. It could be C-fan. No, von Happel doesn't look like it. It sounds like ischemia, which causes new vascularization, and the inflammatory or the exudation transferred to the macula, which we called exaggerated macular response. Could be something in the periphery affected the central
Yes,
area.
exactly.
So again, it's a very good to look at the periphery to find out what's going on in the macula.
Yes, so always for epiretinal membrane, do not consider it idiopathic without dilating the fundus and examining the periphery, regardless, old or young patient. So this is what I always do. OCT is not the final diagnosis of epiretinal membrane. So unfortunately, I cannot pull the fluorescein angiography, so she has an Coates disease in the periphery. So this is an adult form in a female patient with the unilateral Coates disease in adult onset. So I decided to treat this Coates. So I did. So how would you treat it?
If I do fluorescein angiography and I'm sure it's a Coates
Yes.
disease, I will burn out all this periphery. But again, burning out the periphery might increase the membrane because you are heating up the retina.
Exactly.
So you might increase the membrane. So, but at least to treat the pathology first, and if the vision is still impaired, I can go ahead and remove the membrane.
Same, Dr. Ibrahim.
Just why you put Coates as a first diagnosis, although it is a female. Yes, I agree it's unilateral, and still could be any one of the vascular problems happening in the periphery, like von Hebel-Dow or whatever. Why Coates should be the only thing, no oxidation, nothing active. It looks like vascularization.
Don't tell him Coates, tell him Coates-like disease, so he will
Coates-like
not argue.
disease.
Coates-like disease with telangiectasia, heavy vascularization, new vessels, so it's a Coates-like disease.
Exudation,
Because sometimes
yeah.
it's, female is very rare.
But it's 1 to 3. The percent is 1 to 3.
Yeah, but it's
So-
very rare, but again, in this age also, but it Coates-like disease or what we call telangiectasia, peripheral
Yes.
telangiectasia. So that will cut the question.
True.
So the management.
So you will decide to treat this patient because there was already exudation and leak.
What was the vision again, 660?
2025. So
No,
it's,
I will treat the periphery, I will not go to the
yes,
center.
exactly. Because there is a risk those patients will deteriorate to exudative detachment.
I'll do the same, just laser the periphery and leave the center.
If it's a Coates-like disease.
Yes. So I will do the same. So I decided to treat this patient, and this is her right eye. It's absolutely normal. So it's mainly a unilateral disease with peripheral changes with epiretinal membrane. So I decided to treat, and I did laser, and you can see how quietened the area. So the exudation, this is almost 3 months post-treatment. So you can see how the laser treated the primary problem. And her vision until now for 1 year is 2025. So the take-home message from the, so I don't want to discuss Coates because all of us, we know it, but adult onset is very rare, and it's mainly in males, as what we discussed. So my take-home message from this presentation, if you see any epiretinal membrane, please do not forget to dilate the fundus and check for the periphery because it could be a secondary epiretinal membrane. My last question, will you operate this epiretinal membrane or will you refer? No. Okay, thank you so much.
No. I mean, we are treating patient, we are treating vision. What the patient will gain, nothing. It's 2025. The best message here, look at the periphery. Always look at the periphery.
Yes.
Don't look at the OCT because we are not treating OCT. We are treating patients, complaining, exclude everything else. Otherwise, you can be, I mean, if this patient escaped to somebody else and he dilated and he found this, you will be in a big problem. So this is, and I think it happens. She went somewhere else.
And
they
she
told her
was
you have-
not dilated.
You see, epiretinal
Yes.
membrane, nothing to be done, or you need surgery, and they didn't look at the periphery. So this is
Exactly.
a very good message. Always look at the periphery because we are treating the patient.
Exactly.
Thank you so much.
Thank you so much.
It's quick, clean, and I'm glad that we've had the discussion in between. Dr. Muhammad Awadallah, they are going to push you out from the stage, but we will defend you. Double the trouble. So they would be afraid of you because you have a trouble case, so nobody can stop you. Please
don't
go
be
ahead.
afraid, Dr. Magdi.
No.
It will be short, but I don't think will be very sweet. يعني.
Okay.
So, yeah, this is a 33-year-old female. She's asthmatic with obese, borderline diabetes mellitus, with the recent infection with COVID-19. She had severe COVID-19 bronchopneumonia, as we can see here on the high-resolution chest CT scan. History is significant for severe coughing and worsening of asthma. She was admitted to the ICU for 5 days because of low oxygen blood saturation. She was put on CPAP, but no history of invasive ventilation. Dexamethasone was injected according to the protocol in the hospital. Insulin was given for worsening diabetes. She was a borderline. After giving dexamethasone, you have to give insulin. And she was sent home quarantine for 2 weeks and until 2 successive negative PCR. During the whole period and course of disease, there was excessive hemorrhage. She came complaining of acute diminution of vision in the left eye 5 days after discharge from the ICU. These are the medications she was using: bronchodilators, oral steroids, anticoagulants, Eliquis, 2.5 milligram, and insulin. The best corrected visual acuity in the left eye, 0.4, right eye is 1. Anterior segment was unremarkable, and the posterior segment here we can see posterior there is a foveal hemorrhage, and this is the OCT of the case. There is a subile M bleeding obliterating to the fovea. I was trying to link the Valsalva retinopathy with with COVID-19. As usual, we link in the era of COVID-19, we're trying to link anything. So the only history is significant only of excessive coughing and straining. Yeah, and straining. Anyway, it resolved spontaneously within 4 weeks, and the best corrected visual acuity is again 20/20 in the left eye. 1 month later, she came for again acute diminution of vision in the same eye, in the left eye, in the same eye. Patient history, revising the systemic medications, was significant for stopping Eliquis, which is the systemic anticoagulants taken. Best corrected visual acuity in the left eye was 0.05, anterior segment as unremarkable. And what do you think? My question to the panel. RVO. So this is the picture. This is the second impact. This is the second trouble. So obviously it's a CRVO. Here we can see the OCT of the cystoid macular edema, subretinal edema, and she was given 3 monthly injection of ranibizumab for 3 months with systemic anticoagulants resumed. Actually, I sent her for a full blood analysis, and genetics came out negative, everything. Fourth ranibizumab injection with dryness, almost dry, as we can see down. Best visual acuity, best corrected visual acuity, 0.6 at this time. Outer lateral layer destroyed. So, quick reminder of RVO secondary to COVID-19. There are several hypotheses for RVO. The hypercoagulability may be due to 2 mechanisms: the cytokine storm form with the high concentration of cytokines, and the DIC-like form with elevated D-dimer and PTT prolongation and fibrin degradation products. Other factors that could contribute is the hypoxia, the EC2 receptor-mediated endothelial damage due to the high affinity of binding. How would we differentiate? How would it differ from the traditional RVO? According to this study, the age, the mean age was 39.3 years in the RVO secondary to COVID, while 90% of patients with traditional are above 50 years. The risk factors are only there for 30%. Only 30% of patients with COVID-19 have have risk factors. While traditional, we can have diabetes mellitus, hypertension, obesity, hyperlipidemia, and glaucoma. So the take-home message for this is COVID-19 is still a risk factor for developing RVO, irrespective of the age and traditional risk factor. I hope you don't run across those cases that remind you of the past. Every early diagnosis and prompt treatment important for good prognosis. Valsalva retinopathy can develop in patients with severe coughing episodes associated with bronchopneumonia, and monitoring hypercoagulability and inflammatory markers in COVID-19 both are important for prophylactic systemic anticoagulants. Also, we advise against stopping systemic anticoagulants earlier than necessary, while there is a signs of hypercoagulability like D-dimer and other signs, cytokines. Thank you very much.
Thank you, Dr. Mohammed. Thank you so much. That's a nice case to wrap up. And we all know that COVID has been presented with many things.
I apologize for reminding everyone with this.
It is good because we have a lot of complications.
It's a declining now.
Yes.
COVID is declining, but we have seen a lot of cases at that time of RVO.
And most of the cases who survived, they have residual complications in the eye. So I'm glad that your patient has responded well and she is happy. Thank you so much. And we have to conclude this. Please, the speakers come up so we have a picture together. Hazazi, please. Speakers, please come up we have a picture together. Dr. Anura, somebody left? Ahmed Al-Barki, he escaped? Okay. Nobody else? I'm sorry for the cornea people. They are smiling, but they are, grinning their teeth. But anyhow,